Good afternoon, everyone. Why sex and gender-based analysis matters in public health. My name is Ian Colbert. I'm the Executive Director of the Canadian Public Health Association, and I'm very happy to be your host this afternoon. I would like to start by acknowledging that CPHA's offices and my home, from where I join today's webinar, are located on the ancestral and unceded territory of the Algonquin and Anishinaabe peoples. I make this acknowledgement in full awareness as CPHA sends its condolences to the family, the extended family, the caregivers, the friends and community members of the children whose bodies were discovered at the former residential school in Kamloops, British Columbia. I can only hope that this discovery will perhaps penetrate any resistance to reconciliation with Canada's First Nations, Inuit and Métis people, and that anyone who had any lingering doubts about the legacy of Canada's genocidal policies will have them removed. Sadly, we also extended our condolences to the family members of the family that was murdered in London, Ontario recently as an act of terrorism, as an act of Islamophobia. And we recommit to being an organization that is anti-racist and anti-discriminatory, and call on the entire public health community to join us in that. So I wanted to start today's session with a couple of polls to identify who might be in our audience, so we have a little bit of an idea of who's participating today. So we'll start the first one, and if you could let us know from what part of the country or the world you're joining us from, that would be great. We'll give it a couple of seconds for people to vote. Okay. And I think anyone who wants to vote has voted, so we'll just share those results. And who knew it? Ontario leads the pack, but we've got a good split. Unfortunately, the territories aren't represented, but and we have a few international guests, so that's great. Thank you for joining us today. Let's see, we'll stop sharing those and we'll move on to my next question, which is just to get an idea of what your current role in your organization might be. Good to see academia and trainees, students well represented. Excellent. Some senior management, that's important for this issue, absolutely. Okay, and I'll share those results. So academic researchers have about a third, but a good number of trainees and across the board, a good mix. Finally, I'm going to ask about previous training and where you might have received this training. So have you previously completed training in sex and gender-based analysis? And if so, where did you receive that training? Okay, we'll just give it a few minutes, or a few seconds rather. That's good. A lot of people are indicating that they have already received training, so I will end that and share the results. So 74% have received training before, and from different sources, but certainly the CHR online training modules are at the top of this. Way to go, Cara. Excellent. Well, I will not postpone the meat and potatoes of today's discussion any further. So I'm going to introduce all of our speakers in the order in which they will be speaking, and then we'll turn it over to them. So first, Dr. Jackie Gahagan is a medical sociologist and a credentialed evaluator and a full professor of health promotion in the Faculty of Health at Dalhousie University, where they teach community health promotion and program planning, measurement, and evaluation. Jackie serves as the co-director of the Atlantic Interdisciplinary Research Network for Social and Behavioral Aspects of HIV and HCV, and holds a research associate positions with the Jean Monnet European Union Center of Excellence, the Health Law Institute, the Beatrice Hunter Cancer Research Institute, is a founding fellow of the McEachern Institute for Public Policy and Governance, and is an affiliate scientist with the Nova Scotia Health Authority. Next up, we will have Dr. Shirin Heidari, who is the founding president of GENDRO, an association with the mission to advance gender-sensitive research and data analysis. She is also senior researcher at the Global Health Center and research affiliate of Gender Center at the Graduate Institute of International and Developmental Studies in Geneva. Dr. Heidari also serves as Senior Technical Advisor on Gender to the World Health Organization, where she provides technical and scientific advice and strategic support on mainstreaming gender into the work of WHO departments and normative guidelines. Third, we have Dr. Sizulu Moyo, who is a research director leading the Surveillance and Strategic Information Unit within the Human and Social Capabilities Program at the Human Sciences Research Council of South Africa. She also has an honorary affiliation with the School of Public Health at the University of Cape Town, South Africa. Her academic qualifications are a Bachelor of Medicine and Bachelor of Surgery degree, a Master of Public Health and Epidemiology, a PhD in Pediatrics and Child Health in the field of tuberculosis, and a postgraduate certificate in Clinical Research Administration. Dr. Moyo has extensive experience in public health research, where her work has focused on TB and HIV. And last but certainly not least, Dr. Cara Tannenbaum is the Scientific Director of the Institute of Gender and Health at the Canadian Institutes of Health Research, and also serves as Departmental Science Advisor for Health Canada. She is a professor in the faculties of medicine and pharmacy at the University of Montreal, and provides internationally recognized leadership on the integration of sex and gender-based analysis considerations into research, practice, and policy. She champions the use of data to drive decision-making for increasing representation of sex and gender from an intersectoral perspective among those who conduct as well as those who benefit from scientific research. With that, I turn the floor over to Jackie.
Great, thanks very much, Ian. Bonjour tout le monde, welcome everyone. Before we get started, I would also like to acknowledge that I'm grateful to be able to live and work in the unceded, unsurrendered territory of the Mi'kmaq, and that we're all Treaty people. Now, I'm really pleased that we're able to partner with the Canadian Public Health Association on this sex and gender-based analysis in public health webinar. I'm very grateful to Ian Culbert for moderating today's session. I believe it's fitting that this webinar is in partnership with CPHA, and I'll share with you why that is the case in just a moment. First, let me say how very pleased I am that we have a number of contributing authors from our forthcoming book called Sex and Gender-Based Analysis in Public Health, who are here with us today to speak about their work in public health and why sex and gender-based analysis is, or ought to be, a critical component of the public health response to pressing global health threats to human health. Now, in terms of why it's fitting that this webinar is occurring in partnership with the Canadian Public Health Association, or CPHA, at the CPHA conference in Montreal in 2018, Lorraine Greaves, Nancy Poole, Sarah Torres, and I offered a symposium called Adopting the Federal Government's Sex and Gender-Based Analysis Framework in Public Health Policy, Examples from the Field. Now, the focus of the symposium was both to acknowledge and to challenge the level of commitment that Canada has had in relation to sex and gender-based analysis, noting that in 1995, the federal government formalized its commitment to sex and gender-based analysis following the Beijing conference. The symposium that was held at the Canadian Public Health Association conference served as the genesis for the forthcoming book called The Sex and Gender-Based Analysis in Public Health. And some of the content will be highlighted in this webinar by our speakers. So I'm very grateful to Janet Kim from Springer Publishing in New York, who attended our symposium and approached us afterwards to ask if we would consider developing a book proposal on the topic. The outcome of that conversation is the forthcoming edited volume of 14 book chapters divided into 3 parts, including part 1 called The SGBA Terrain, which includes a chapter by Dr. Heidari called Missing in Action, Sex and Gender-Based Analysis in Public Health, part 2 called SGBA Matters, which includes a chapter by Dr. Moyo called Tuberculosis and the Relevance of Sex and Gender-Based Analysis, and part 3, which is called The Responsibilities of Public Health, which offers a chapter called Translation, Implementation, and Engagement by Dr. Tannenbaum. As those of you who have undertaken a book project where you are both a contributing author as well as a co-editor, you can appreciate the amount of effort that it takes to get a project such as this across the finish line. In this regard, I'm deeply grateful to my co-editor, colleague, and dear friend, Dr. Mary Bryson, for their invaluable leadership in moving this book forward to completion, despite the various challenges along the way. And here we are, some 3 years later, and I'm truly thankful to Springer for seeing the merit of our book proposal, noting that this book represents an important effort to address the long-standing gaps in the application of sex and gender-based analysis in public health policies, programs, and related interventions. This book brings together leading experts in the field of sex and gender-based analysis in public health from South Africa, Sweden, Australia, the US, and Canada, who speak to the urgent need to move beyond theory toward the actual integration of sex and gender-based analysis in our public health efforts. It's important to note that despite Canada's long-standing commitment to sex and gender-based analysis, there's been a variety of challenges preventing the widespread integration of this approach across federal departments and agencies. As indicated in the report from the Office of the Auditor General of Canada, only a fraction of federal departments and agencies that committed to, for example, implementing the action plan on gender-based analysis had, at least at that point, actually conducted gender-based analysis. This lack of uptake matters in that sex and gender-based analysis as an analytic process can be used to determine how diverse groups of women, men, boys and girls, and gender diverse people are differentially impacted by federal initiatives. It's noted in the literature that a badly developed public health policy may be challenging to address or correct using a post hoc SGBA approach. The point is to ensure that we're addressing intersectional inequalities at the outset of our public health policy development processes and not as an afterthought or an add-on to satisfy a pro forma developmental reporting requirement. If SGBA is truly meant to assist government policymakers, including those in public health, in identifying sex and gender considerations ranging from participation and inclusion of diverse populations, thought then needs to be given to these issues in the developmental phases and not solely in the evaluation phase of this work. In addition to the content that we covered in today's webinar, where you'll find a variety of examples in our forthcoming book that will be touched on briefly today, but the book that we came up with out of the Canadian Public Health Association conference in 2018 is called Sex and Gender-Based Analysis in Public Health. It's important to think about some of the examples as illustrations of the work that is yet to be done. For example, in relation to cancer screening and cancer registries, we question the ongoing invisibility of lesbian, bisexual, and transgender populations in what is often referred to as women's cancer screening programs, which may in fact overlook the unique cancer diagnoses, treatment, and care needs of gender diverse populations. In addition, cancer registries, which, as you know, collect, store, manage, and analyze data on people with cancer to help with cancer surveillance, as a resource for cancer researchers, and to serve as the evidence base to inform actions taken by public health officials, this too can benefit from an SGBA approach. If cancer data are collected using a gender binary of male or female cancer populations, for example, this information is then fed into the cancer registry, which in turn renders invisible those who identify as gender non-binary, transgender, or other gender identity. How can we inform gender and sex appropriate cancer prevention, care, treatment, and support programs or policies in such instances? Another example that I touch on in the book involves the exclusion of cisgender women living with HIV from early clinical trials of antiretroviral therapy due to issues of pregnancy, hormonal fluctuations, concerns about adherence, etc. What this led to was the extrapolation of data from these clinical trials based on men with HIV to women living with HIV. In this example, there's a need to understand both the ways in which gender-based social norms impact on HIV infection rates between, as well as those in relation to adherence to HIV treatment, which can cause challenges in living arrangements or contexts where gender-based violence exists. The exclusion of cisgender HIV positive women from these early clinical trials on HIV treatment and the extrapolation of clinical data to women living with HIV overlook not only the social context and norms that place individuals at differential risk for HIV infection in the first place, but also the pharmacokinetics of HIV drug absorption rates, side effects, and the resulting challenges in adherence to treatment. It's also important to note the systemic exclusion of women living with HIV from these early clinical trials were disproportionately impacting women experiencing multiple intersecting social, economic, and other disadvantages due to structural issues such as racism, sexism, and poverty, etc. I'll now turn it back to Ian to introduce our next speaker. Thank you.
Thank you so much, Jackie. So next up, we have Shirin Heidari. Shirin, the floor is yours. Unmute yourself, sorry. It's only been 16 months.
There we go. Well, thank you so much, Ian and Jacqueline, for the invitation to this discussion. It's a very timely conversation. It's a topic that is very close to my heart, so I never get tired of speaking about the issue. And I also congratulate you, Jacqueline and Mary, for your leadership in your forthcoming book on sex and gender-based analysis in public health. And thank you for allowing me to make a small contribution to that book. I think that will be a very important resource for all of us. I just want to kind of start by drawing attention to a publication in the Lancet in 1973, which really points to the importance of this topic and this book. It writes that gender or sex differences are well recognized in almost every area of medicine, but despite an enormous growth in knowledge of the mechanism underlying sexual differentiation over the past 25 years, they are still poorly understood. And now here we are, nearly 50 years after this publication. And while our knowledge about sex and gender in health has advanced and is of course much more sophisticated, we still have important gaps in our knowledge, and we're still struggling to take into account these important variables in public health research and global health practices systematically as a matter of routine. And this is partly, this overlook is to a large extent due to a history of a male-centered medical research where the man or the white male body has been the point of reference. Historically, women have been excluded from health and medical research, education and profession. And in medicine, women were long considered a smaller version of men where doses could be adjusted to their smaller size and interventions were assumed to work equally well for women as for men. This is, of course, a reflection of the deep-rooted gender norms in our society, where men have been given greater power and privilege, and masculinity and manhood have been considered inherently superior to femininity. We now recognize that these gender biases are not only harmful to women, but also these rigid gender norms and notions of masculinity also disadvantage men, and most importantly, gender diverse individuals. Thankfully, these assumptions are being questioned and challenged, and much thanks to the women's health movement and other health advocates, there is now a growing awareness of the earlier medical sexism and gender-specific gaps in health research. And in fact, in the last decade, we have seen an amplification of commentaries, statements, and viewpoints that exposes the gender biases in research, policy, and practice, and a growing number of efforts and initiatives that aim to address this gender gap. These efforts are also promising as they produce a greater and more in-depth understanding of the complex interplay between sex and gender, as well as their interaction with other social determinants to influence and impact our health and well-being. Our knowledge about the influence of gender has also been expanded to include structural and institutional dimension of gender in terms of public health governance, policies, and programmatic implications. For example, we recognize now that the notions of gender are embedded in political, economic, and social and cultural systems where norms are shaped and reinforced, and where these influence how power and resources are being distributed. And this is, of course, reflected in the health system very well. Institutional gender can influence the way information, public health information are formed and disseminated, how the public health system are designed and operated, and clearly influences how public health programs are planned, funded, implemented, and utilized, which in turn influences priority given to women's, men's, and gender non-conforming people's health services, decisions about which services should be offered. This is particularly the case of sexual and reproductive health services, resource allocation, quality of services with respect to sexism, racism, disrespect and abuse, and discrimination in healthcare settings, workplace policies for healthcare providers as well as researchers, and of course, participation in decision-making about all of the above. We're also now linking these gaps and biases also better to human rights and the human rights implications. We know that failing to take into account sex and gender aspects in research is not only about good science, but it's also about equity and human rights. Biased, incomplete, and fragmented evidence can render individuals' needs invisible, as Jacqueline very well articulated, and ignore the experiences of women and other marginalized populations, and in turn can violate the right of all to equal and non-discriminatory access to health services, the right to enjoy the benefits of and protection from the harmful effects of scientific and technological development. And also the Convention on the Elimination of Discrimination Against Women obliges states to ensure that data collection and use reflect the real world experiences of women, and that any conclusions reached are supportive of equality. And of course, the same principle applies to gender non-conforming people and gender diverse people and men. And this growing awareness and this increasing number of efforts is creating a momentum for change in the public health research and practices. The public health institutions and the culture within them needs to be really aware of the gender biases within that. And we really need to embrace a gender transformative approach to public health. An approach that acknowledges that the research processes are not value-free and objective, as we always have been learned to think so. In fact, every step of the research process is subjective and gendered. Decisions about what public health research topics are important to be funded, what data are collected, how data are collected, from whom, how data are analyzed, and what gets published and constitute the body of knowledge and evidence. And beyond that, what evidence is being used to inform public health policies and intervention. All of these are, of course, informed by gendered assumptions about quality, relevance, merit, and impact. Luckily, we have seen great kind of focus and efforts across the knowledge production system. We have seen, and we will hear more about the leading efforts by public funding agencies who are promoting and fostering incorporation of sex and gender dimension in research. We have seen that peer-reviewed journal editors and publishers have been taking up efforts to improve the reporting of sex and gender dimensions. And these are more promising efforts. There are also areas where there is much needs to be done in terms of regulatory agencies and research ethics committees. Even in the context of funding agencies and publications, we also know that while these efforts and advances are much welcome, there is still a lot of work needs to be done to really reinforce and implement these positive and promising policies that comes. And in the research ecosystem, the various gatekeeping functions have a great power to shape the knowledge that is being produced and underpins the policy and action. And again, the forthcoming book is a great resource to all students, teachers, public health researchers, and practitioners to support the transformation of our public health research approach that can systematically consider sex and gender differences across this continuum, one that takes into account the influence of gender norms and gender hierarchies on distribution of power and resources in public health. Otherwise, we will fail to ensure an equitable approach to public health that meets the health needs of all. And I will stop there. And again, thank you so much for listening and looking forward to our conversation.
Great. Thank you so much, Sharon. Great segment to get us going on this. I just want to remind people that you can pose questions using the Q&A function at any time, and we'll certainly respond to them after all of the presentations. So don't hesitate to ask a question early. So next up is Dr. Sizulu Moyo. So if the floor is all yours, if you want to unmute yourself.
Thank you very much, and thank you for the opportunity to participate in this webinar, and congratulations to Jackie and the team for the book that's coming up. As a person who was trained in clinical medicine, I think it's been a steep learning curve, also in my research work, just understanding the nuances around sex and gender and in the work that I do. And I think that participating from South Africa is very important. I sense that we may be far behind just from the discussions that have been happening to where maybe Canada is. And so this is very important, especially for an institution such as the one that I work for, in how we can move this agenda forward, given the issues that we are facing now in South Africa. I'll move on to my presentation. Hopefully I'll be able to share my screen. There we go. Okay, can you see it?
Yes.
Okay. All right, I'm using two screens, so it's a little bit confusing. Okay, so my area of work is really around tuberculosis and HIV, but mainly tuberculosis. And so my contribution with my colleagues to the team to the book was around TB, and we looked at the importance of sex and gender analysis in tuberculosis. So I thought I would start by just giving a brief overview of the epidemiology of tuberculosis. I know that in some countries, such as Canada, America, and other European countries, TB is no longer such a big deal. It still is there. We know that there are different, burdens in different areas, but because of the way in which the world operates, the TB that we have in high burden countries can still, be seen and be transported to the low or burden countries. And I know that sometimes in some of the work that is done in Canada and other places, for example, you do talk about TB in those who are foreign born and those who are native to the country. So it's very important. So just to say that TB, we know that is airborne, is caused by bacilli. It mainly affects the lungs, but also can affect any other part of the body. It really is a significant cause of morbidity and mortality. So it's a significant public health issue. It's something that we cannot ignore, even now when we talk about COVID and other issues. For us, and I think other parts of the world, is a really big issue. As I've said, it's mainly prevalent in low and middle income countries, mainly in Asia and Africa, but there's no country in the world that has completely eradicated tuberculosis. In this slide, what I've also shown is a figure from the Global TB report of 2020 that looks at the global trends in the estimated TB incidence. I just want us to focus on the two red circles that I put there. So the first one, if you look at, maybe just to orientate you to the figure, at the bottom, we've got the years from year 2000 to year 2020, and then we've got the rates per 100,000 population. So if you look at this red circle at the top, you can see that we still have a lot of TB. If you look at it per capita, per 100,000 population, it's just under 150,000, 150 per 100,000 population. And if you think about how TB is transmitted, That is not something that we can ignore. So as we think about it, it's a really significant public health issue. At the bottom, you can see in the dotted line, the circle there at the end, the targets for 2030. That is where we're supposed to move. We're supposed to move from just under 150 per 100,000 to about 30 per 100,000 for us to reach a level where we can say that we're eliminating tuberculosis. So I think this gives us the context of why it's so important for us to think about sex and gender analysis in tuberculosis, given all the other efforts that have been directed towards TB, given also where we are despite those efforts that have already been put in place. Now, just to talk about the sex and gender context, as I've said before, TB is caused by bacilli, so it's a particular germ, but sex, gender expectations, gender roles, gender norms, as has already been said, and other health determinants also affect and determine our risk of acquisition of the bacilli, our risk of developing tuberculosis, how we access TB healthcare services, the quality of healthcare services that are received, and at the end of the day, the treatment outcomes that then pertain to tuberculosis. Now, generally, TB data is reported by sex and age. And I think the two previous speakers have spoken about how sometimes the broad stroke of sex, binary male and female, just overlooks some of the discrete differences by maybe the gender non-conforming people or other gender diverse people. And so this is what I'm trying to illustrate from this slide. So when we look at it by sex and age, which is what you see when you read documents like the Global TB Report, when you read country reports, and many other maybe articles in journals, you just see this binary disaggregation, male and age, and also male and female, and also by age. What we see is a higher male TB burden. So already one can think, okay, this is really a problem of males, but that is not the only picture. If you drill down and you look at it from a sex and gender disaggregated analysis, then you begin to see that there are other issues that are happening as far as that burden is concerned. I put in there that by age, the greatest risk is in children under 2, and then you have got the burden increasing, correlating with age, with the bulk of the cases in younger middle-aged people, 25 to 34. I've already said that the sex and age disaggregation is helpful, but it masks the epidemiological differences by region and differences driven by gender influences. There is data that in some countries, like Afghanistan, like Pakistan, and like Iran, and I'm sure there are other countries, the burden of TB is actually higher in women, which is contrary to what everybody thinks who works in the TB field, or what we generally see when we look at TB data. We also know that women in the reproductive age group bear a significant burden of TB, with up to 10% of maternal mortality attributable to TB, even in a country such as South Africa, where we think that we've got good maternal health services. I show you here in this figure just a figure from the Global TB Report, also 2020, which just shows us the global estimates of TB incidence just by male and female. And just by looking at this only, there's a lot that one can miss if we think about how we can then approach our fight against TB from a public health perspective. Now, I've already spoken about the issue of TB in pregnancy and say that it is a leading cause of mortality in women in the reproductive age group. TB in pregnancy can easily be undetected and undiagnosed. We know that symptoms like weight loss, they can be masked because people gain weight when they're pregnant. We also know that you may have, things like night sweats, which can easily be missed as it can be taken as a sign of just being pregnant. So we need a high index of suspicion, and without a high index of suspicion, these TB in pregnant women can be missed. We also know that frequent pregnancies promote reactivation of latent TB, since we know that when people are pregnant, there is changes in the immune system. So any latent TB can really be activated. And without TB, without treatment, TB in pregnancy can be passed on to the baby in utero, or postnatally there is congenital TB, and this is associated with high risk of poor outcomes in the infants. So I show you there two pictures, and this is something that we see in our part of the world. The very top picture is a woman who is accessing care in an urban center. She's got all the information, and she's probably be tested or screened for TB. At the bottom, you can see somebody who is likely to have many successive pregnancies very close to each other. And if there is no index of suspicion, this type of TB can really be missed and be closed over. Now, one cannot talk about TB without talking about HIV, because it's the most significant comorbidity in high TB settings, even amongst people who are on ART. Now, the impact of HIV is greatest in pregnant women, as I've already said, and we know that HIV is most prevalent in women in the reproductive age group in high HIV burden countries. And we also know that from a gender perspective, they face enormous challenges in terms of accessing services for women, and in particular also for tuberculosis. HIV is also high in vulnerable and key population groups. And one of the key groups that has been identified in South Africa are transgender women. We have evidence of them not being able to access care, where they actually denied care when they try and go to approach health services. However, we also know that there is very limited data in this population group. So without that nuanced sex and gender-based analysis, this type of people or TB in these populations can easily be missed. And the thing with TB, because it's airborne, we can pick it up from that person when you are at the shop, when you are at the bank, or when you are using public transport services. So it's very important that our public health approach is very targeted and also addresses analysis at this level to disaggregate data so that interventions can then be appropriately directed to the relevant population groups. Now, in terms of social and cultural norms, I think in my part of the world, these are just huge. I mean, the higher TB burden in men, we know, is also partly driven by social cultural norms. We know that TB is airborne, spreads in crowded and poorly ventilated places, and more men work outside the home. I think globally, although things may be different in other parts of the world, and men tend to socialize more outside the homes. In South Africa, where what we call taverns or shabins, where people sit and drink and smoke, and there is TB there. And so because of the more social contacts, they are at a greater risk of tuberculosis. Also, although the profile is changing, we know that generally more men take alcohol and also use tobacco products, and these are associated with a greater risk of TB. What is significant is that while this is affecting men, when men pick up TB from wherever they may be, they can come back to the household and then pass it on to women who may be at home. Now, there are also gender and sex-specific occupations that drive tuberculosis. One of the key ones that we face, that we know about in South Africa, is mining. I think most people know about the consequences of gold mining with regards to tuberculosis and silicosis in South Africa, in South African mines. And in fact, it stretches out to the whole of the Southern African region. Also, construction workers are also exposed to silica dust. And where women may also be affected is crowded factory settings where there is poor ventilation, and women are expected, more than men, to work in those type of settings. In terms of healthcare seeking and access to health service, I think this was also mentioned by the previous speaker. We know that although in many countries TB is free, but there are other costs associated with TB, with seeking TB care. In fact, the WHO now does these studies that are looking at catastrophic costs that really are so catastrophic and destroy the incomes of families. We know that gender norms in many areas mean that women depend on men for cash. So if they don't have the money, they may not be able to go to the facility to get their symptoms, TB symptoms checked out. Women may also require male permission to seek care. Sometimes it's not only the spouse, it may be the spouse, it may be the father-in-law. So these are the gender norms that exist in some parts of the world. And also women's health may be of a lower priority. So if there are competing demands. There may be a thought that, okay, you just wait until we deal with this first before we deal with your TB. So that's already a barrier that women face. The gender roles may also limit care seeking in the sense of what women are expected to do around the household. And this mainly affects women, in my part of the world, where there are household tasks, caring for the young and also caring for the elderly, while men go out to work. And men, on the other hand, because they work, the way in which public health services are designed, the clinics that open at 8 and close at 4, these men are at work, so they cannot access, TB services during that time. And sometimes it's very difficult for them to take a time off from work to go to the facilities. And because of stigma also, men don't want to attend the clinic that may be down the road from their workplace. We want to go to a place where we are not known. So these are some of the issues that come into play. Also, the social cultural concept of menhood also limit men from seeking care for their TB symptoms. There are studies that were done in Malawi that I can think about, where there is a feeling that having TB or seeking care for TB symptoms makes men feel like they're emasculated, like they don't want to go to the healthcare facilities because there's no privacy. Everybody can see that Mr. So-and-so has gone to the clinic. And women also take longer to be diagnosed and to placed on treatment. And this was actually very striking because when we looked at the data, this is universal. In Australia, this was reported. In the UK, this was reported. So it takes longer for a woman to go for a test, maybe to be offered a chest X-ray, or to be offered a sputum test, or to be offered a CT scan, than it takes for a man. So the time from presentation to diagnosis to treatment was longer for women across the board for TB. And sometimes healthcare workers stigmatize transgender people, as I've already mentioned in an example from Cape Town. I've spoken also about TB stigma, and this really affects both men and women, just given the nature of tuberculosis. But the data shows us that it mainly affects women much more than men. The picture that I'm showing you in the slide is of a TB patient who had drug-resistant TB, and this patient was in Khayelitsha in Cape Town. And this is one of the campaigns that is ongoing, that we should not stigmatize people who have TB. And this stigma is much more felt by women more than men. And it was also interesting from the data that some people believe that TB is sexually transmitted. And therefore, women who have TB are seen as being promiscuous, and this has got dire consequences for their lives, for their lives and also for their livelihoods. I'm going to skip the rest. I think you can read it there. So I want to conclude by saying that gender roles significantly impact the risk of developing TB, the burden of TB, access to care, and care and treatment outcomes. Sex and gender synergistically influence the transmission, spread, and outcome of efforts to control TB. Sex and age disaggregated indicators and gender-sensitive indicators are essential in understanding and guiding evidence to address the TB burden. I think that most of the world has been very good at looking at sex and age, but the gender-sensitive indicators, which are very well articulated by UNICEF and also by WHO, I think those are lacking. And it's quite striking because in South Africa, we just finished our first national TB prevalence survey. And I can tell you that there wasn't much of the gender-sensitive analysis. It was the broad disaggregation, male sex, where people live, urban, rural. And so this means that as we tackle the TB disease, if we do not really drill down and analyze the data, our interventions are not going to be very well targeted. And we may find that we remain at this place where we feel that our TB burden is plateaued. We need to do something that will help us to move it down much more quickly for us to reach the targets by 2030 and 2035. One other thing that we found in the literature in preparation for the book was that we need consistent use of terminology on sex and gender within TB research and TB reporting, so that public health workers and policymakers can better utilize the data. for effective interventions against tuberculosis. That is my last slide. Thank you very much.
Thank you so much, Dr. Moyo. And I'll turn it right over to Dr. Tannenbaum. The floor is yours.
Merci beaucoup. Il fait vraiment plaisir pour moi d'être ici parmi vous aujourd'hui pour participer à cet événement. Real pleasure to be here. Congratulations, everyone. And also thanks to the attendees for participating. I was asked to say a few words on the significance of SGBA for CIHR, the Canadian Institutes of Health Research, and maybe a word or two on the focusing on gender transformative approaches to public health. So to make a long story short, the SGBA policy, Canada has a sex and gender-based analysis policy that was introduced almost 15 years ago, and we take it very seriously, as many of you know, and as I was thrilled to see by how many of you had completed the CIHR modules. Not only do we take it seriously, but we have a sex and gender-based analysis and research action plan. You can see the screenshot from our website here. Please go to it if you want more information. And you'll see in that little box, there's some key dates. For instance, in 2010, we started requiring that applicants who wanted research money justify and explain how they were going to take sex and gender into account in the design, methods, analysis, and reporting of their research. And here's a graph along the x-axis. You see the different years of the competition. You'll see that in the light, brown squares, you see how gender was taken into consideration by all peer review committees at CIHR. The light green circle is how all committees take into consideration sex. And the PH1 committee, we just randomly took the Public Health 1 committee, you'll see in the dark lines. And there's a number of inflection points in this graph. For instance, in the fall 2011, we started saying, well, if you're not going to take it into consideration, please tell us why. And that certainly led to more engagement. Overall, the trend lines are really impressive. You'll see there was a dip down in the spring of 2014 and again in 2018. So let me tell you what we did to get those numbers back up and running. Overall, though, we're pleased with the way public health researchers are accounting for sex and gender, but there's always room to do better. Here's a timeline of our interventions. I told you that in 2010, we introduced the mandatory self-reporting for applicants, and we got a bit of a uptick when justification was required. In 2014, when the graphs had plateaued, we started introducing sex and gender champions on certain competitions. And in 2015, we introduced the sex and gender online training modules that I think really help support applicants understand what's necessary. Then in 2018 was one of my favorite interventions. It's when we started requiring mandatory assessment of sex and gender by peer reviewers. And we've spent the last 2 years developing really tailored interventions, coaching, answering questions for reviewers on how it affects their discipline in particular. And then this year, I'll show you how we're incorporating the scores. So here's what, if you're not a peer reviewer, if you're not an evaluator, here's what evaluators get. They actually cannot submit their score unless they check off whether the applicant used sex and gender as a strength of the application, if it was weak integration, or if it was not applicable. And we require them to write why it's may not be applicable, or to use the space to say how they could be integrating it better. So when people are forced to write things, they think about it and you get better accountability. And then this year, of course, we are now giving instructions that the evaluation of sex and gender must be considered in the overall strength and weakness of the application, in the sense that it would influence the score the same as a design flaw or the same as improper analysis might. And what this has led to is that sex and gender have essentially become a key component of the definition, the actual value of research excellence. So these graphs very quickly, just to show you that we do use data to monitor our interventions. That is a hallmark of what we do. You know, on the x-axis, you'll see the competition cycle, and on the y-axis, you'll see the odds of successful funding if 2 or more reviewers score sex or gender as a strength. And you see the odds ratios here with 95% confidence intervals. And these are significant, meaning that proper integration of sex and gender in your application is now a robust predictor of whether you will get funded. So tell that to everyone you know if they want to know how they could increase their chances of getting a CIHR grant. A few words about integrating sex and gender-based analysis in public health, specifically as regards gender transformative interventions. And this is something that we talk about in the translation and implementation chapter of the new book that's being launched. Many of you are familiar with the WHO Gender Responsive Intervention Assessment Scale. And if you want to learn more, I refer you to the book and work by Lorraine Greaves and Nancy Poole and Ann Peterson, where they explain how interventions, if examined critically, can actually be categorized as gender unequal, where you might exploit stereotypes and perpetuate gender inequality. And then on a range of gender blind, fair, but not great results. Gender sensitive, considers and acknowledges gender issues, but maybe doesn't do anything to change that. Gender specific, where you intentionally target and benefit a specific group, where you accommodate, I guess, the gendered roles and behaviors and stereotypes that exist that are harmful, towards what we aspire to in public health, which are gender transformative interventions that transform the way we mitigate harmful gender roles and relationships in the outcomes that we hope come from the interventions. You know, I could use human papillomavirus or HPV as an example, typically thought of as a woman's disease because it's associated with cervical cancer. But in fact, 45% of 18 to 59-year-old men in the US, for instance, have been shown to be harbingers of HPV. And so when you start to think of gender transformative interventions in public health, you might consider males as asymptomatic carriers or HPV reservoirs. And here I cite Franklin Pratt, who said that it is very safe to say that if all males were immunized against HPV, substantial benefit would accrue to all sexually active people. So great project for one of your students, or if you're a student, do this with the research that you're doing. Plot what different interventions might look like along the gender responsive scale. So if you consider HPV as a woman's disease, we're really exploiting women are responsible for their health and men have no real roles to play. Gender blind might say vaccinate male and female adolescents equally. But there's stigma against gay male teens. So if that's not addressed by the physician, then parents might think, oh, I only need to vaccinate my son if he's gay, and that might lead to poor uptake. What's the obvious answer? Maybe gender transformative would be to target men as HPV reservoirs as well as women to achieve herd immunity, something that we're trying to do with COVID right now. Other examples of exploitative messaging and knowledge translation in public health is this anti-smoking campaign ad, obviously showing a woman and saying your future's not pretty. See, the ugly side of smoking really appeals to a very gendered perception that women have to be pretty in society. So somewhat exploitative. Again, you know, smoking during breastfeeding, this ad on the left, women who smoke feed more than just milk to their children? Or shouldn't we perhaps be moving towards transformative campaigns where you see a father and a mother together or parents together saying, kick the habit for the health of your children? So even in how we advertise and communicate, it's important. My favorite gender transformative public health intervention is the snow clearing gender balance policy that was implemented in Stockholm, Sweden. Many of you may have heard of this. For those of you who haven't, I refer you to Carolyn Criado Perez's book, Invisible Women, which is an excellent accounting of this. What the Swedish government or Stockholm municipality said, okay, we want to reduce pedestrian injuries. Well, 79% occur in the winter. Most of them occur in women. Why did they occur? It's because people are slipping or falling on the ice. this is amazing. They actually said, well, does gender have anything to do with that? You know, we see a sex difference. Does gender have anything to do with it? Proper use of gender-based analysis, sex and gender-based analysis. And they said, well, let's see, the way we clear the snow is we clear the big streets first. Those are the streets that more typically gendered occupation men take to get to downtown to do work in the finance area, for instance. But the smaller streets where people walk, take their kids to school, maybe get to the hospital, those who don't have cars need to use those smaller streets and sidewalks to get to buses. That's where a lot of the falls are happening and where we don't really clear the snow till later on. And in fact, the cost of pedestrian industries, they discovered, was 3 times higher than the cost of snow clearing. So, you know, good or bad, it ends up being an economic argument, but they designed a gender balanced snow clearing system where they decided to reverse it, clear the sidewalks, bike paths, and smaller streets first, then clear the smaller roads to the hospitals and schools, and last clear the snow from the larger arteries. And they achieved a 2-fold decrease in pedestrian accidents from this approach. And you could see the citation there from the counselors in Stockholm's traffic department. So this is how you might do a gender transformative intervention. I'll leave you with a thought about the future. Once we've got sex and gender down pat, I would reiterate that intersectionality is important. I hope we move towards identity-based approaches that consider intersectionality in our research. And I'd say that COVID has really opened everyone's eyes to that. I see great promise, and we depend on you to make it happen. So that's all, folks. Go forth and conquer. Thank you.
Thank you so much, Cara. That was great. So we only have a few minutes left and we have a few questions. So I'm going to jump right into them. So the first one is to Dr. Moyo, asking, is TB elimination by 2030 the SDG goal and 2035 for eradication? May that be possible? What's your thoughts on that? So perhaps if you quickly wanted to address that.
Yeah, I think I have my doubts about elimination in 2030. And I think my doubts, some of them are underpinned by some of this discussion that we're having today. Are our interventions targeted to those groups that still face a higher burden of TB? We can look at the broad statistics and say, for example, take my country, South Africa, and say, okay, our TB burden is declining, but it's declining slowly. But are we looking at the people who are actually facing the greatest burden so that we can deal with those hot spots? So I think that I'm not entirely convinced that if we do not change the way in which we operate, the way in which we use data to target our interventions better to those most at need, I think addressing inequality, which can also be driven by how we use sex and gender-based analysis to direct us, that will help us get there. I also think that obviously COVID has come into play. We know that apart from all this, what we're talking about, there's been a lot of diversion of resources and diversion of maybe our focus to deal with COVID. So I think that has thrown a spanner in the works. Thank you.
Thank you so much. Another question, I'll leave it open to who would like to answer first, but can you share a best resource to guide and promote the consistent use of gender-sensitive terminology? Anyone?
I was going to suggest that on the heels of Cara Tannenbaum's talk, people could check out the CIHR website for training modules and clarification on some key terms that would be helpful in that regard. Also, Shirin's work with GENDRO, there's also SAGER guidelines. There's lots of material out there that will help direct people into how best to deal with those issues going forward.
Great, thanks, Jackie. Another question, as most determinants of health and wellness lie outside the health system, any advice for generating buy-in among provincial government departments outside of the health and education sector where GBA plus or SGBA data and capacity is lower? Very Canadian question. Cara or Jackie?
I mean, any sector that receives federal funding certainly has to deliver on the gender-based analysis policy. Certainly any budget requests need a gender-based analysis to be funded. Some provinces are starting to do that. Certainly the funding agencies in the provinces are starting to incorporate sex and gender as requirements for funding. So I think, you know, it's ego or fear, go with fear. You know, we should really start thinking about this because I heard that they're asking for it and we better start measuring it because we don't want to look bad and lose our funding. So that would be my kind of strategic advice there.
Great, thanks. Another one quickly, hopefully. My institution resists including transgender and gender diverse people in SGBA due to low percentages of the people in the population, especially in older adults. Do you have any ideas how I can push back on this?
One, it's ethically unacceptable. We are starting to get complaints across Canada to ethics committees that when you don't recognize, value, and acknowledge a person's right to affirm their identity in questionnaire or in data collection, it really goes against the responsible not only conduct of research. You can mention that Statistics Canada is currently expanding the way that they collect identity information. And finally, I think that it harms the individual. And even if you have low numbers, if only all long-term care institutions would publish a cell with the small numbers of transgender or gender diverse individuals, then across the country, we could pool that data to see how outcomes change or health conditions change among this population. So as with any analysis, perhaps you don't have to show significance, but please include the cell, even with small numbers, so that it could be pooled and combined for meta-analysis so that we can get good answers and use data to support this very important population. Jackie, something to add? I know it's an interest of yours.
No, I think that for the sake of time, I think that was a great answer. Thanks for that.
Super. So we'll just do one last question and then we'll wrap up because we're just past the top of the hour. The question is, what do you think about industry data being used to fight for policy change as well? Technology has created the perfect source for big data to learn about gender demographics so long as it's controlled for bias.
Well, that's a big so long as. I don't know if someone else wants to take this one, but we know that there is tremendous bias in algorithms, you know, in data systems, the data that fed into the, you know, into Google. Even like if you write bride, you'll probably get a white woman with a white veil, and you would have to put performance art or costume art to get a picture of a bride in India. So yes, I think that products and innovations need to consider gender. Here, I recently participated on an advisory group to the European Commission. So just type gendered innovations policy report into Google, and there's about 30 case studies for industry on how to take sex and gender into consideration for robotics and user design methods, and also in many other industry related fields, including the development of drugs and medical devices.
Excellent. Very good. I will turn it back to you then, Jackie.
Thanks very much, Ian. In closing, I'd like to express my sincere thanks to the Canadian Public Health Association, and in particular, Ian Culbert, for hosting this important webinar, as well as a big heartfelt thanks to our presenters, Sizulu, Shirin, and Cara. I'd also like to thank our contributing authors on our forthcoming book called Sex and Gender-Based Analysis in Public Health, which will be available for pre-order on the Springer website. And thank you as well to Janet Kim from Springer, New York, for inviting us to take up the challenge of this book project. Merci beaucoup. Thank you so much, everyone. Over to you.
And just as we close, I've posted in the chat box a link to a webinar on Thursday on sex and gender consideration and COVID-19 vaccines. So that's from Shirin's group. So thank you to all of our panelists. Look forward to seeing this book. Thank you to all our participants. Thank you for your questions. This session has been recorded and will be posted to CPHA's YouTube channel, and you will receive an email about that as soon as it becomes available later this week. Have a great day. Take care of yourself and be kind to each other. Bye-bye.